On behalf of McLaren Port Huron, hello and welcome to this educational program on stroke prevention and treatment. I'm your host, Kelly DiNardo. Today, we'll be hearing from Dr. Omar Basha, a neurologist with McLaren Port Huron. At the end of the presentation, Dr. Basha will answer any questions that you may have. Just send them to me through the chat feature and we'll get through those questions at the end. So Dr. Basha, thanks so much for speaking with us during Stroke Awareness Month.
Hi, it's a pleasure to be here. Hi, again, my name is Dr. Omar Basha. I'm a neurohospitalist over at McLaren Hospital, and it's a privilege to be there. Basically, the lecture is about strokes, and I'll try to be brief, but to the point. And if there's any questions, leave it to the end, and we'll be more than happy to address any issues. All right, then, let's begin. So, what is a stroke, basically? A stroke occurs when a blood vessel that carries oxygen and nutrients to the brain is either blocked by a clot or burst. When I say burst, what I mean by that, it ruptures. So when there's a blockage or rupture, when that happens, part of the brain cannot get blood, therefore cannot get oxygen, and therefore the brain cells die. So stroke is the number 5 cause of death and leading cause of disability in the United States. And that's prior to the COVID-19. What types of strokes are there? There's 2 types. There's ischemic and there's hemorrhagic stroke. Ischemic comprises of 85%. Hemorrhagic comprises of 15% of the strokes. Now, talking about ischemic stroke, it's a clot obstructing the blood vessel to the brain. When there's now phrases such as a mini stroke, a transient ischemic attack. What does that mean? It's temporary blockage, blood flow to the brain. Usually patients have symptoms such as weakness, numbness, etc. And their symptoms resolve. So the terminologies are exchangeable: mini stroke, transient ischemic attack. Again, as I mentioned, strokes, 85% of the strokes are due to blockage in the brain. Now, what are the causes of ischemic strokes? There's a broad range. The most common cause is atrial fibrillation. This is irregular heartbeat of the brain. There's also atrial flutter. So basically on right here, the schematic, we have atrial fibrillation. When you have irregular heartbeat, there's a blood clot that forms in the heart. And what happens is, and then it goes to the blood, to the heart. It forms in the heart, then it goes all the way and it travels to the brain. And then you develop an ischemic stroke. Another type is you have a plaque causing ischemic stroke. So here we have a carotid vessel, and there's a plaque filled up of cholesterol, calcium, and that kind of breaks off and goes to the brain, causing the stroke. Here's another schematic of the embolus blocking the blood flow to the brain. As I mentioned earlier, also we mentioned hemorrhagic stroke, and that comprises of 15% of the stroke. So that happens when a weakened blood vessel ruptures and bleeds into the brain. So when you have uncontrolled high blood pressure, eventually these vessels or any vessels ruptures, causing the vessels to rupture and bleed. This is a schematic. This is a CT of the head, and we're looking at a bleed in the brain. This is the bright signal here. That's where the bleed is. Now, what are the signs, symptoms of stroke? So you have weakness. You can have weakness of the arm and leg, or just arm and leg by itself. It's either on one side of the body, both sides. You can have clumsiness of the hand, difficulty getting your words out, garbled speech, difficulty understanding. You can have double vision, You can have partial vision loss or complete vision loss. Again, it all depends on what part of the brain it's affected. You can have a facial droop that causes eventually, if the facial droop is very significant, causes slurring of the speech, choking while swallowing, numbness, tingling, either in an arm, leg, face. Your gait is unsteady. People describe it as they feel like they're drunk while walking. Loss of balance. So again, there's a phrase of be fast. B stands for balance. E for eye. You can have again, as we mentioned, you have double vision, vision loss. F stands for face, right facial weakness. A stands for arm weakness. S stands for speech. As we mentioned, your speech is slurring, garbled, difficulty. People have a hard time understanding your speech. And T for time. So with stroke, every second counts. So if you notice these symptoms, call 911 immediately. What are the risk factors of strokes? So the risk factors of stroke is obesity. The more your weight is, the higher risk of a stroke. If you're a smoker, and it depends how long you've been smoking for also. You're diabetic, and especially if your diabetes is uncontrolled. High cholesterol, you have heart condition. We mentioned about atrial irregular heartbeat, such as atrial fibrillation, atrial flutter. Also, basically, having coronary artery disease, blockage in the heart can lead to a stroke. History of heart attack can lead to a stroke. As we mentioned, high blood pressure, sleep apnea can lead to a stroke. Lack of exercise, heavy alcohol use. So alcohol use in moderation is okay, but heavy alcohol use leads to a stroke. And we'll dive those more in a bit. Again, what are the modifiable risk factors? Things that we have the ability basically to control is high blood pressure. You want to keep the blood pressure less than 140/90. Higher than that affects the vessels and leads to a stroke. Diabetes, as we mentioned, increases risk of stroke. And patients with diabetes have a higher risk of strokes than non-diabetic patients. I mentioned earlier about heart disease. It's the second most important risk factor for stroke. Smoking doubles your risk of stroke. High red blood cell counts, basically. The clot kind of clump up. As a result, there's a lack of oxygen to the brain, so it leads to risk of stroke. High cholesterol and lipids. It thickens and hardens the artery, leading to atherosclerosis, causing a buildup of plaque, as I mentioned on my earlier slides, of the vessel image in the carotid. And that plaque can break off and travel to the brain, or lack of blood supply from the carotid. If it's very significant, it can lead up to a stroke. Lack of exercise. The more you weight, the higher risk of a stroke. We talked about excessive alcohol use. More than 2 drinks per day raises your blood pressure. And binge drinking can lead to a stroke. Illicit drug use, such as cocaine, IV heroin, that increases the risk of heart attacks, other cardiovascular problems, strokes. I mentioned this multiple times. Abnormal heart rhythm, such as atrial fibrillation, atrial flutter, etc., can increase the risk of stroke. And cardiac structural abnormality, valve heart disease can cause long-term heart damage and over time increases the risk of a stroke. Age, basically, you can't modify your age as much as we try. The older the more you blossom, your chances of stroke will increase. And it is noted that more than age of 55, your chances of stroke increases. It doubles or more. Your race, African Americans have much higher risk for death and disability from strokes than whites. And this is basically because of greater incidence of high blood pressure. Usually African Americans have, for the most part, higher blood hypertension, uncontrolled give and take. Gender, strokes occur more often in men, but women than men die from strokes. History of prior strokes. If you have a history of TIA or stroke in the past, that increases your risk of a stroke. And genetics. Father, mother, they had, family members had a stroke, that puts you at a higher chance of a stroke. What is the workup? So we, once upon come to the hospital, we check the blood pressure to see what it is. We get a CT of the head to see, is there a bleed or is it an ischemic stroke? We want to know what we're dealing with because the management is different. So with this patient, they came to the hospital, they had stroke-like symptoms, and a CT of the head was done, and it was normal. There's no bleed. There's no one side stroke than another. And I'll show you an example of an ischemic stroke on my next slide. This one. So this patient comes in with stroke-like symptoms on the left side, left-sided weakness, vision loss. So with this patient, we can tell the difference. The arrow shows where the stroke is. This dark portion, that's where the brain got affected, basically. So, and I won't get too technical, but the right side of the brain controls left side of the body and vice versa. Left side of the brain controls right side of the body. So in this patient, we got a CT in the head, and here we see a significant, a large stroke on the right side of the brain. So the reason why we get a CT of the head is there's a clot busting medication that once you have the symptoms, you come into the hospital, you call 911, don't wait. And then we have a stroke team. We'll get a CT of the head. The stroke team will evaluate over the robot. This is Dr. Maju over the robot. And we have other stroke attendings. And then you'll, after getting some workup, basically the basic stroke workup, then we'll see, hey, do you qualify for this clot busting medication? You have up to 4.5 hours from the stroke onset of symptoms. So here we got vessel imaging. Basically, we get CT of the head and we get vessel images to see whether is there a blockage in the vessels, basically. So here on the left side, and so in radiology, things are switched. So here it's the vessel is basically filled up. It's normal. Here it's clotted off. So basically, if there's a clot, then you can qualify for intervention. And I'll talk about that down the line. So after coming in and the CT is normal, stroke team will basically evaluate you. We'll get some blood workup. As I mentioned, for clot busting medication, for TPA, you have up to 4.5 hours. For retrieval of the clot, for this one, to get it out, basically, it just depends where the clot is. You have up to 24 hours, give and take, basically. So this is a slide regarding the exclusion criteria of the TPA. And I won't get too technical on this. It's basically for the stroke attendings, basically, and they know this verbatim. So there's a criteria that you qualify, you don't qualify for this clot busting medication, and we'll kind of determine that. Basically, if a patient had a stroke within 3 months, then they don't qualify. If they had history of a bleed, etc. Now, a patient qualifies for this clot busting medication, and there's a clot right here. We give them that clot busting medication, and there you go. The clot breaks off, and the blood flow is restored. And this patient's smiling after getting the TPA. I talked about this, causes and management of a stroke. So there's large vessel, small vessel, embolic, systemic. So large vessel, the workup, basically, you get vessel images, and I showed the vessel images. Basically, is there a blockage in the carotid, basically? So we get images of that. We get images of the brain, the vessels in the brain. For the small vessels, basically, we check the hemoglobin A1C, the cholesterol, lipid panel. We check the blood pressure. Smoking, history of smoking increases the risk of small vessel strokes. Cardioembolic, such as irregular heartbeat and things like that. Basically, we'll get an EKG, we'll place the patient on a Holter monitor. We get also ultrasound of the heart and echo. We also we usually place the patient on a loop recorder, or we send the patient on a Holter monitor to monitor where did the stroke come from. Because when the patient comes in for a stroke, we're trying to find out all the time, was this as a result of blockage from the neck vessels? Did it come from the heart because of irregular heart rhythm? So we work the patient up in the hospital. If they're young, we do hypercoagulable workup, like genetics, stuff like that. History of cancer can increase risk of stroke, things like that. As I mentioned, irregular heartbeat can increase the risk of stroke. So we place the patient on cardiac monitor, and we'll monitor the patient while in the hospital. And when they're discharged, we'll place them on an event monitor, Holter monitor, or loop recorder, and they'll be on it for about 30 days. And then to see, hey, can we catch any irregular heart rhythms, basically, that led to this stroke? I mentioned in my previous slides, we get vessel imaging of the brain. So Dr. Maggio and the rest of the team, Dr. Navratla, Dr. Reyes, they're the stroke team, and basically they also do intervention. So if there is a clot, basically, they go in from the groin, and then they retrieve the clot to allow blood flow to go back to the vessels. So they'll make that decision after vessel imaging, if there's any blockage or not. So basically they'll go in, and let's say there's a clot right here, they'll get in and they'll basically retrieve it out. After they retrieve it out, the blood flow will go back to the brain, and hopefully the symptoms resolve. So in the hospital, after getting those workup, also physical therapy will be working with patients, as well as speech therapy. And at the end of it, every patient is a stroke survivor, and we take every patient gets high quality care at McLaren Port Huron Hospital. And that's basically about it. Any questions?
Thank you so much, Dr. Basha. This is great information. I do have a couple questions, and I encourage people, if you have a question, just send it in through the chat. So why does smoking and diabetes increase your risk for stroke?
So they affect the vessels, basically. They cause atherosclerosis. So they harden the vessels, basically.
Are TIAs a precursor for stroke?
Yes. So usually TIAs are precursors for the stroke. So if you have any symptoms, stroke-like symptoms, and your symptoms resolve, call 911. I really recommend, I see some patients say, oh, my symptoms resolve, because your symptoms resolve temporarily, but they can come back right again, and they can come with more severe symptoms. So if you come in right away, possibly there's a blockage here, and your brain is telling you, hey, there's a blockage, get it addressed. So patient says, oh no, they resolve. And then 6 hours later, their symptoms are worse, and that's it. Basically, they their symptoms are more severe, it's more damaging. So if they would have came in the earlier, the better to address it, basically.
Yep, I love that phrase, that brain, time is brain, right?
Yeah.
That's the mantra for our stroke center. A question, and it's kind of relates to that one. My husband had 20 mini strokes. Is there a difference between, can you explain that difference between a mini stroke and a stroke?
So again, mini strokes is, so 20 is a lot. So mini strokes, again, patients have symptoms, slurring of the speech, weakness, numbness, etc. The list goes on. And there are symptoms to resolve. And they can resolve within 24 hours. We get images, it's normal. So that's called a mini stroke. Now, the mini strokes, as I mentioned, or TIAs, that increases risk of a stroke. If he's having that many, I would also get addressed. Why is he having that many? To get more investigation, more workup.
Can you talk a little bit about TPA? How effective is it, and how does it affect someone's recovery after a stroke?
Yes, so TPA is very effective. Now it can, with TPA, basically you have up to 4.5 hours, as I mentioned earlier, from the stroke symptoms of last onset. So let's say and I have to address this. Again, if you have symptoms, don't question yourself or anything like that, or justify, I'm not gonna go. No, come. So basically TPA works for the most part is 4.5 hours from the onset of last normal, okay? So let's say somebody had their symptoms at 11 o'clock in the morning. 12 o'clock in the afternoon, they had symptoms. Call 911 and come, and then we'll decide whether TPA, if the patient qualifies for TPA or not. Now, let's say the patient slept at 11 p.m. And then they woke up at 7 o'clock. So and so when they woke up, they noticed their symptoms. So basically, the last normal considered is 11 o'clock at night. Now, how effective it is? It's fairly effective. Now, is it guaranteed for every patient? No. But again, if you qualify for it, I would recommend getting it, basically, because you might be one of those people that will benefit from it. Is there a risk of TPA? Yes. There's a risk of a small percentage of bleed, basically. But the benefit outweigh the risk. If that answers the question.
Yes, I think so. Another question. So if someone has a history of stroke, does that lead to maybe other health conditions? I was just thinking Alzheimer's was one that you hear that someone that's had history of stroke, are they at risk for other conditions?
So if somebody has a history of a stroke, does that lead to other things? So basically, when you have a stroke and it's very debilitating, you can develop pneumonia, basically, because let's say you have difficulty swallowing. So you aspirate, possibly, again, not every patient, they aspirate, they're in bed, they can't cough, they're drooling, so they aspirate, they develop pneumonia. They can develop DVT, clot in the legs or arms, because they're not moving around. But when you're in the hospital, we try to move patients around. Basically, you're not as active, basically, when you have a stroke.
Yep. Any other health conditions that you think could impact?
That's basic. That's for the most part that I can think of, basically.
Yeah. I think it all comes down to circulation, right? That's
circulation,
the whole,
exactly.
yeah. Yeah, very good. I don't see any other questions. Do you have any other closing comments for us?
No, What I say is, if you have stroke-like symptoms, please do not second guess yourself. Please come to the emergency, call 911 immediately. Don't even think about it. Let the stroke team decide what they want to do, what
Yeah.
workup we want to do, basically. And, as we mentioned, again, time is brain. Every second counts. And, we have a great stroke team at McLaren Port Huron Hospital. Our patients can, they can advocate for us. I know we do a great job, and wherever you're at, even if you're traveling somewhere, just call 911 if you have stroke-like symptoms, and let us know about your history, what medication you're on. Also, be compliant with the medications. There's patients that have irregular heartbeat, so sometimes they miss, basically, they ignore taking their medications, or they forget, or things like that. I think what helps is having a pill box and having reminders that they need to take the medications. Avoid smoking. We counsel that many times to avoid smoking. Not only for stroke purposes, it makes you look younger, feel better.
Right. Great. Thank you so much. This has been really helpful information, very timely during Stroke Awareness Month. So thank you for spending this time with us and providing this education.
It's a pleasure.
Yeah, thank you. Have a good day, everyone.